This evening, we have a distinguished panel of discussants on the issue of cancer incidence, mortality rates, and trends in Westmoreland, looking back from 2003 to 2018. And so I welcome you to the first of these meetings. But we begin by receiving remarks from the founder of the main organizer of this event and chairman of the MistyBlue Cancer Care Foundation, Miss Dorothy Satchwell. And so I invite Miss Satchwell to bring remarks.
Hello, ladies and gentlemen. Hello. Good evening. My name is Dorothy Satchwell. You need to unmute. My name is Dorothy Satchwell. I'm the chairperson for MistyBlue Cancer Care Foundation, which is a charitable cancer education support group that is specifically for the parish of Westmoreland and its environs. This foundation started back in March 2015, which was after I had a personal experience with breast cancer. And it was out of my experience and the deficiencies as it relates to the provisions for cancer that I came up with the idea to launch this foundation. So we, as a foundation, we normally offer a series of health education programs across the parish in the form of health fairs, health presentation in churches, schools, clubs, and societies. We also do fundraisers so that we can offer assistance to the persons in the parish who are suffering from cancer. And we're also seeking to assist the Westmoreland Parish Development, the Westmoreland Hospital, by providing a CT scanner. So we have been doing a fundraiser for that. So because of COVID, we have had to cancel all of the planned activities we had for 2020. And therefore, the idea of this teleconference came about so that we can keep you abreast of what has been happening in the parish as it relates to cancer. So this evening, we are going to be looking at general cancers, and we are going to be moderated this evening by Dr. Nkrumah Young, who is a past vice president of planning, operations, and finance at the University of Technology. And we have a series of presenters, as he has said, who are specialists in cancer and other areas, and also a survivor. So ladies and gentlemen, I will now take my bow and hand back to the moderator. And then I ask that we all sit and enjoy and learn from the presentations that we have as the evening unfolds. Thank you very much.
Thank you, Chair. And as I said before, we have a series of distinguished persons, and I invite now one of the patron of the MistyBlue Cancer Care Foundation to bring greetings. She's no other than the Honorable Dizela Makala, a child of Westmoreland. Though she grew up she was born in St. James, she then did her early education in Westmoreland and then moved on to the University of the West Indies and the Norman Manley Law School, and have had a distinguished career in law. She was a clerk of the court, then Crown Counsel, and then assistant director in the office of the Director of Public Prosecution before becoming a resident magistrate and a master in chamber of the Supreme Court, a pre-unit judge, and finally the Chief Justice for the island of Jamaica. We're indeed proud and happy to have such a distinguished person as the patron and greeting us this evening. Honorable McCullough.
Thank you, Mr. Moderator, for that lovely introduction. I too am very happy to be here this evening, and it is my very pleasant task in my capacity as patron of the MistyBlue Cancer Care Foundation, as you have heard, and I extend cordial greetings to all persons who have joined us for this, the first of these cancer awareness events being conducted in this virtual format due to the COVID-19 pandemic. Nevertheless, I welcome this opportunity to join you at this time. May I extend special greetings also to the founder and the chairman, Ms. Dorothy Satchwell, and members of her executive team. I would be remiss in not making special mention of my fellow parishioners in Westmoreland, the parish of my birth. And that's the parish in which the foundation is based. I also take this opportunity to thank all persons who have worked tirelessly to make this the first in a series of planned events a reality. The foundation has successfully staged numerous events in Westmoreland and neighboring parishes since its inception in 2015. Our expectation is that the planned series of events will serve to heighten public awareness of the negative impact of cancer on patients and others who care for them. As citizens, we must do all that we can to reduce the death rate due to cancer. Statistics show that in Jamaica, there's a very high cancer mortality rate, and the death rate in the parish of Westmoreland is, of course, particularly high. Cancer is everybody's business, as all persons are at risk. And I'm sure that many of us have had loved ones who have succumbed to this illness. No one entity can deal with the problem. We have a collective responsibility to play our part. The foundation has been successful in forming several partnerships in staging numerous events. The planned series of events, educational events, will also highlight the excellent work that is being done by the foundation in this area of cancer care and cancer prevention. It is my hope and expectation that other entities, both in the private and the public sector, will partner with the MistyBlue Cancer Care Foundation in its endeavor to bring more awareness of the impact of cancer on the lives of those affected. This would enable the foundation to achieve even greater success. And so in closing, I thank the foundation for all those, I thank the foundation and all those who have lent their support to its worthy cause. And I wish for a successful outcome in the case of each event to come, and I do look forward to sharing in them. Thank you very much.
Thank you so much, Honorable Justice McCullough. And so now we move to the heart of the matter, as we are going to get some hardcore information, as I now invite Dr. Mong Hung. I hope I got that right. And I'm saying to everybody, I'm not the person to mispronounce anybody's name because I suffer from that daily. But nonetheless, we are going to hear from a scientist and epidemiologist who is representing the Chief Medical Officer of the parish of Westmoreland. And he's going to give two presentations. One is on the cancer mortality data for Westmoreland. And then after he does that, we're going to come back as we look at prevention strategy. Dr. Arnold.
Thank you so much, Mr. Chairman, and good afternoon, everyone in the Zoom. And I'm going to share my screen. All right, so thank you so much, Mr. Chair. So you actually, yeah, you pronounced my name correctly, so thank you so much for that. My name is Dr. On, I'm medical epidemiologist. Before I start, I would like to thank MistyBlue Cancer Foundation for giving me this opportunity. And like you mentioned, I'm going to be doing two separate presentations. One is going to be looking at mortality in the cancers in Westmoreland, and the other is epidemiology of cancer and preventative strategies. So this is the outline of my presentation. I'm going to start with the epidemiology and going to describe some statistics on cancers globally, nationally, as well as in Westmoreland. And I'm going to be talking about descriptive epidemiology of the cancers in Westmoreland, as well as in Jamaica. And we're going to briefly describe the risk factors. And then now going to show you some evidence, research, and findings locally as it relates to cancer prevention and control and prevention. And I'm also going to highlight what Ministry of Health and Wellness is doing about cancers. And I'm going to be ending with a summary of my presentation. Now, before we continue, I would like to start with what is cancer? Cancer that we know of today is also known as malignancy and also known as neoplasm. Cancer is a large group of the diseases that can start in almost any organ or tissue of the body when abnormal cells grow uncontrollably, go beyond their usual boundaries to invade adjoining parts of the body and or spread to the other organs. There are a little over 200 different types of cancers that can occur in human body. Now, we look at a population structure which is relating to the cancer mortality and morbidity in this country. And in the bottom of the page screen, on your right, on my left, is the population structure over 40, 50 years. And when we start looking at 1970s, our Jamaican population pyramid is almost made up of younger generation. And in 2020, as we improve in terms of infectious diseases and people are living longer, we are having antibiotics to successfully treat infectious diseases, which can kill people very easily. And we have started to see people are living longer. Now, when we hit 2050, you can see our population pyramid is going to be shaped of, I'm not sure what this is. Most of our population is going to be made up of elderly population, 50 years and over. One of the contribution factor also is on the top of the screen. In Jamaica, the fertility rate in Jamaica is steadily declining from 1950 to 2020. So people are living longer, people are not having children. So that is going to give us, end up with the elderly population. As people are living longer, chances are that persons are going to be ended up with some of those non-communicable diseases such as hypertension, diabetes, and also cancers. So that's something that we need to be mindful about. And we have to strategize in such a way that how are we going to be taking care of this population? And we have to put our healthcare services to align with what's going to happen in the future in terms of our population. In 2080, there is a paper published by GLOBOCAN and which estimates the incidence and mortality worldwide for 36 cancers in 185 countries. The paper said that in both sexes, lung cancer is the most commonly diagnosed cancers, followed by female breast, prostate cancer, and colorectal cancers. In male population, lung cancer is the most commonest cancer diagnosed, followed by prostate cancer. In female population, breast cancer is the most commonest cancer diagnosed. at this point in time, I would like to introduce the terminology called Human Development Index, HDI in short. It is a summary measure of the average achievement in key dimensions of human development, such as a long and healthy life, being knowledgeable and have a decent standard of living. That is the definition by UNDP. In other words, if a country scores a higher HDI, when the lifespan is higher, the education level is higher, and the gross national income, or GNI, per capita is higher. In other words, the country is doing relatively well in this regard compared to other countries. Now, using that HDI and describing top 5 leading causes of death globally. So you can see there are 15 top leading causes of death worldwide in 2016, and second is being cancer. Is leading causes of cancer. Leading causes of death is cancer. Now, if we have countries with low HDI, and cancer is not the top leading cause of deaths, it is going to be infectious diseases. They are struggling with infectious diseases, and for medium, high, and very high HDI countries, cancer is in the top 5 leading cause of death. So where Jamaica stands in terms of HDI, Jamaica is classified as high HDI, and that explains to us that cancer is the second leading cause of death in our population. Now, looking at the cancer burden in the Caribbean, in 2018, in the Caribbean, prostate is the top leading commonest diagnosed cancer in male population, followed by lung, colorectal cancer, stomach, and larynx. For female, breast cancer is the most commonest cancer among female population, followed by colorectal and lung cancer. In Jamaica, prostate cancer is the most commonest diagnosed cancer among male population, followed by lungs, colorectal cancer, stomach, non-Hodgkin lymphoma, followed by prostate cancer. In female population, it is the breast cancer is the most commonest cancer diagnosed, followed by colorectal cancer and cervix. This is the graph from World Health Organization published in 2018. As you can see here, they describe both incidence and mortality rate for all cancers in Jamaica. And prostate, breast, and colorectal cancer and lung cancer are not only that they are higher in incidence, they also are leading causes of death in terms of mortality, especially prostate cancer. Even though the data is a little bit old, this data is published by Gibson et al. And they also describe the fact that in men in Jamaica, in the island, local study, as we go along over the years, prostate cancer incidence has been increased. So is breast cancer in women population. When we come down to Western Regional Health Authority, which is Westmoreland, Hanover, Trelawney, and St. James, we have persons visiting Cornwall Regional Hospital with the cancer. And the similar trend is being observed in male population, prostate cancer, followed by colorectal cancer and lung cancer. And female population, breast is the leading cause of diagnosed cancer visits to the Cornwall Regional Hospital. So just trying to make the point that the trend in the Caribbean, Jamaican, and local populations are similar in that regards. Now, looking at the Westmoreland parish individually. Westmoreland, for some of us who are not from Westmoreland, Westmoreland is located in westerly part of the island, a population of 145,000, a little over 145,000. In terms of commerce activity, sugarcane cultivation is the most activities in Negril. Westmoreland is known for Negril, where the most attractive tourism is most popular activities there. And eastern part of the parishes, you can see farming is one of the activities there. population structure for Westmoreland over the years, population has been increasing steadily from 2001 to 2017. And the population in Westmoreland is made up of persons over 30 years and older. Male to female population is almost 1:1. If you remember HDI that I previously described, Human Development Index, now looking at individual parish within the country, Human Development Index for Westmoreland is lower than that of national figure, and also lower than that of parishes from the eastern and southern side of the island. In terms of health service delivery, we have Westmoreland Public Health Services, and they have a network of health centers, namely type A, type B, type 1 to type 5, and they are being located strategically throughout the parish. And we also have a secondary care where we have government type B hospital, 200-bedded hospitals, and providing services of emergency services, medical services, surgery, ONG specialties, and pediatric specialties. Westmoreland also have 1 private hospitals contributing to the medical service provision in the parish, along with many private practitioners who are also contributing to the health of the population in Westmoreland. Now, we looked at the leading cancer deaths in Jamaica by parishes. This data is taken from Registrar General Department. So this is the mortality data. So it does not speak for incidence or prevalence of cancers in Jamaica. So when we look at the number of deaths, in general sense, on average, 23% of deaths in Jamaica are due to cancers. And the similar trend is observed in Westmoreland. 23% of all adult male deaths are due to cancer. And the type of the cancer is that similar in all parishes in the country. In terms of female population, 19% of the deaths in adult female populations are due to cancers. And the types of the cancer is similar in all parishes as well. Like I said, it's breast, followed by colorectal cancer, and so on. Now, looking at the individual cancers, this is the cancer of stomach in Westmoreland. It fluctuates. There is no specific pattern that you can see cancer deaths in Westmoreland due to stomach cancer. Colorectal cancer, it seems as if we are seeing the increasing trend of persons who are dying from colorectal cancer in Westmoreland. For lung cancer, similarly, there is no particular trend that fluctuates, but it seems as if we are also seeing the increased number of persons that are dying from lung cancer in Westmoreland. For cancer of the breast in female population, this is a female breast cancer, and we also noted that increased number of persons are dying from breast cancer in Westmoreland, starting from 2014 to 2018. When we look at the cervical cancer, cervical cancer of the cervix, again, similar trend is observed. There's no particular trend. We are seeing increased cases of persons are dying from cervical cancer in Westmoreland. Now, prostate cancer in men, obviously, we are also seeing the number of persons, especially men, are dying from prostate cancer lately. The increasing trend is observed in prostate cancer deaths. So, in summary, looking at these 5 different types of cancers, you can see neoplasm of prostate. Prostate cancer is the leading cause of death among population in Westmoreland, followed by lung cancers and followed by breast cancer. So those are the top 3 cancer killing people in Westmoreland. So for this presentation, in summary, for Jamaica, is classified as high human development index country, and cancer is the second leading cause of death in the country. For Westmoreland, we have relatively low. Westmoreland is relatively low HDI. 5 of 10 persons are 30 years and older, so we are looking at a little bit older population. The cancer deaths is not the highest in the country. 23% of deaths among men and 90% of deaths men, women. And no specific trends is observed in individual cancer deaths. Prostate and lung cancers are more leading causes of death in Westmoreland population. And in male population, prostate is the leading cause of death, and female population, cancer of the breast is the leading cause of cancer in Westmoreland. All right, I don't know, I need to pause or I need to continue for the next presentation. Mr. Chairman?
I think we could pause for a while. I don't know if there is any particular question here before we go on to the next one, but just to give us a little breather. And, with that, I just ask you, Dr. Ong, is there a relationship between the Human Development Index and the increased rate of death, cancer death?
Thank you for the question, Mr. Chair. Am I unmute? Am I being heard?
Yes, you were here. Neil.
Okay, great. So I don't think something has been studied locally, but internationally, yeah, there is a relationship between HDI, higher HDI, Human Development Index. Is if you're looking at the country with persons who are well off and healthcare services are at standard, and also persons education attainment, so that the health scheme behavior is going to be positively related to the persons who are going to be seeking care in early stage of their diseases. So if you're looking at high HDI countries, the cancer may be detected in early stage, and even though they are listed as the second leading causes of death, because people are living longer, so they are going to be end up with one of those conditions, that they're going to be dying from one of those conditions. And one of the top conditions that kill the people globally is the cardiovascular diseases. So even though you are having more technology advanced and all of those human specialist supports and all of that, and we are getting more and more persons are diagnosed with cancers. But the catch is that if you have a system which can provide palliative or comprehensive care to the cancer, that is what we are looking at.
Mm-hmm. So would you say that the Human Development Index is increasing in Jamaica, but at the same time, the rate of cancer is increasing?
It may not be directly related to it, because like I said, people are living longer and we have technology advanced. When I was in medical school, we may not necessarily have mammogram and other technologies. Now we have advanced technologies, and persons are more aware of their body changes, or they started to seek care early stage. So they started to screen what's happening in their body. So we are finding more cancer cases. So that means we are seeing increased cases of cancers. It doesn't mean that we are seeing the people who are having more cancers. It doesn't mean that persons are having more cancers. It may mean that we are finding more cancers among population because of the technology and specialties that we can offer to the population right now.
Thank you very much. I call on everyone to, you could use the chat in the Zoom to pose your questions, or you could pose your questions via WhatsApp as we go through, and give Dr. Ong a chance now to switch his presentation and get set now for the second presentation as we come through. But we are noting, as he's doing that, I'll just comment that we're noting that the Human Development Index is increasing, but at the same time, when we should be having more information to get us through and to make our lives go longer, we still see that there is an increase in death rate from cancer. And, calling out to my researchers that might be an area that we need to look at and study carefully so that we can get more answers. Are you ready again, Dr. Ang?
Yes, sir, I am.
Okay, you go ahead for me, please.
All right, before I start, I would just want to make a comment on your last comment that you have made. Way ahead of my presentation. So I'm going to be addressing some of the queries that you have in this presentation. So please follow me. So we have looked at the numbers globally, nationally, and also locally at the parish level. Now we are going to be talking about epidemiology of cancers. So epidemiology is being defined as the study of the distribution and determinants of health-related status in specifying populations and the application of this study to control of health problems. So epidemiology of cancers that I'm going to be talking about is the study of the distribution and determinants of cancers in specified populations. In this case, Jamaican population, populations of Westmoreland, and the application of the study to control of cancers. So we look at the distribution. So I'm going to be focusing on determinants of cancer at this point in time. So when we talk about determinant, we're talking about risk factors for cancers. So there are two major groups, non-modifiable risk factors and modifiable risk factors. Obviously, non-modifiable risk factor, there is nothing we can do about it. Being older, there's nothing we can stop being old. And being a man, we're going to have a problem with prostate, which our counterpart may not have. And also for women population, they're going to have a problem with their cervix, which we don't have. So, there are in some cancers or some particular race are more susceptible and having cancers than other race. And family history, particularly someone who has a family history of immediate family history of first generation family history of cancers are more susceptible to have a cancer as well. Now, looking at modifiable factors, this is a infection, tobacco use, handful use of alcohol. Now, this study was done in Jamaica by Gibson et al. And as you can see, age is something to do with it. Most cancers are being diagnosed between age 60 and 75 years old age group. So as we get older, we are diagnosed with the cancer. And the similar pattern is seen in Cornwall region as well. So we are seeing more persons are coming to the hospitals with advanced stage of cancers, and those persons are at older age group, and we are diagnosed those individuals in the Cornwall Regional Hospital. This is also showing that as you get older in female population, the mortality from the breast cancer is higher. So age is something that we have no control over. I talk about race, higher rate in African American population for particular cancers, and that particular cancer is also observed lower in Asian population. Now, family history, first degree relatives. If you are having first degree relatives having cancer in the family, you are susceptible to have cancer at one point in time. Now, looking at the modifiable risk factors. Now we are looking at obesity. Jamaican Health Lifestyle Survey number 3 that was published in 2016 and 2017, which was done in Jamaica. 1 in 2 Jamaicans, almost half, were classified as overweight. Now, looking at Westmoreland population. In Westmoreland population, in male population, the male being overweight in male population is second in 14 parishes in the country. So that's not very good. And for female population, they are not doing very bad. They are not doing bad. For female population, they rank 8 in terms of being obese. So in general, in the parish of Westmoreland, the being obese in parish of Westmoreland ranked 3rd among 14 parishes in the country. So we are seeing at the obese population in Westmoreland, one of the risk factors of having cancer. Now, physical activity. Only 82% of Jamaicans were engaged in low physical activity, such as walking, going around in the yard and so on. But we are looking at less population who are less engaged in high physical activity, moderate to high physical activity. Only 60% of the populations are engaged in moderate physical activities, and only 2% are engaged in high physical activity. Now, dietary practices. The same study has that found that 28% of our population drank a sugar-sweetened beverage once or more daily. 1 in every 10 persons consume excess salt or sodium by adding salt at the table, or frequent consumption of salty sauces and high sodium processed food. In terms found that 41% of almost half of the population of 50 years and older age groups use alcohol. But for tobacco use, it's not so bad. And 50% of 50 years and older use tobacco product, current use. So looking at the Westmoreland parish, this is the data from National Council on Drug Abuse. And they did the rapid assessment and response survey in 2010. And 34% have higher use of, have ever used cigarettes, and 8% are current use. And 12% have ever used cigarette, and 11% have ever used BD. That's another type of cigarette. And 37% have ever used ganja, and 91% ever used alcohol. So basically, what we are looking at is that in Westmoreland, alcohol is the most abused drug in Westmoreland. 76% consume alcohol. Why do they use it? 76% said they use to feel good and relax. And the majority of them, most of them who use alcohol, they know that they are aware of the dangers of the alcohol use. And one of the things that we need to be worried about is when you are under the influence. 3% have had an unprotected sex under the influence of alcohol, and 1% has had an unprotected sex under the influence of other drugs. Now, the other risk factor is a human papillomavirus. Human papillomavirus is responsible for the cervical cancer and cervical cancer deaths among female population globally, worldwide. And why we are being susceptible to contract human papillomavirus in the country is that the same study has found that we have early sexual initiation, and in male population, 50 years they start to have sex, and female 16 years. That was published in 2016 and 2017. One of the things that we need to pay attention to is only 3 out of 10 persons use condom during the last sex. So we are looking at the population who are not using condom every time in the last they have sex, and that's where the infection, not only HPV, is also transmit HIV as well. And the worry trend that we are observing here as well is that 70%, 7 out of 10 Jamaican women ever take pap smear. So 3 out of 10 persons have never done pap smear in this country. Just to point out that HPV, human papillomavirus, is a necessary cause, but it's not a sufficient cause, and we have to be mindful of the other factors which contributes to the cervical cancer. Now, I'm going to be sure look at some of the local studies that we did in Jamaica. We did the 2 studies about prostate cancer knowledge practices and also epidemiology of prostate cancers in Jamaica, and particularly in the Western Jamaica. What we found was most participants in our 2 studies from rural area. And another studies also found that 28.2% of Jamaican men 40 years and older have ever done digital rectal examination. So this is one of the methodology that we do for examination of prostate. There is a slight increase over time, and I also know that we have some increase over the years up to 2007, 2018. For another type of diagnostic tools that we use is the prostate-specific antigen, which is also trying to assess the status of the health of the prostate. And only 5% of the Jamaican men 40 years and older were sent by healthcare providers for prostate-specific antigen tests. So this is also alarming. And another study also found that older men tend to screen for prostate cancer in Jamaica. But something that we would like to lower our threshold, or we would like to detect prostate cancer in early stage and in early part of their lives. Although persons, on the other hand, older men come to the healthcare facility for prostate cancer screening, but compliance with the regular maintenance visits and requests for confirmatory biopsies are poor. So they are not following up, if we recommend for, hey, coming back for your biopsy, coming back for your follow-up visits, they are not sticking around. So which is also worrisome. Another findings that we did, that this study is done for prostate cancer knowledge, attitude, and practices. This is the cross-sectional study. And also, please bear in mind that this is the quantitative study, it's not qualitative. What we found is that most participants did not know what and where the prostate is. And only 35% were previously screened, just to support what our previous findings suggest. And if persons for men, population of men who live in the rural area and who has never been advised by their doctors and who are not visiting for healthcare providers for regularly are less likely to be screened. So this is the typical of our Jamaican men. They don't want to come to a health facility for their checkup. So at the time, we have recommended men 40 years and over, we are going to be focusing health education, particularly on regular visits. It's just only for your prostate. It's just and we're also going to be focusing on the prostate cancer screening for this particular age group, men 40 years and over. Now, another case control study that we did in Jamaica, in western part of the country, including Westmoreland. Most persons know screening of prostate, but fail to visit doctor for tests. There is a knowledge and practice gap that we have identified. Most cancer patients are sadly were diagnosed, only one symptom appear. So when they started to show signs and symptoms, and they show up at the health facilities, and cancer may be at the late stage. And we also found the non-modifiable factors such as age, family history, and alcohol, modifiable factor, alcohol use, are associated with the cancers in the western part of the island, including Westmoreland. So we have to do targeted intervention. So we have to be targeting on those with low knowledge, attitude, and practice score, and targeted intervention as, and we're going to be targeting on health education about those population. We're going to be targeting on men with family history. We're going to be targeting on men who drink a lot alcohol. So we have to be focusing on targeted intervention. And we also have to identify why the disconnect between knowledge and practice. And that and also we are aligning ourselves to improve the screening rate at our health facilities. So these are the recommendations from that particular study finding. For female population, what we did the interventional study, where we started with describing what is the cervical cancer, what is the breast cancer to the female population at a setting. And after we described them, presentation was done, demonstration was done, and after that we asked, we administer questionnaire as to how much did they pick up from our presentation. And we see the improvement in terms of knowledge. But after 6 months or 10 months, we follow up, we call them individually and try to find out, based on what you picked up from our presentation and improve the knowledge, how many of them are actually following through with the screening of their breast and CS cervical the organ. And we have found that 22.4% were screened for breast cancer and 77.6% had not been screened. So you still identifying the gap. Even though they know about it, they still are not doing screening. There may be the other factors we need to look at. And another study has found that fear may be the factor for the female population to participate in mammography screening. However, it is to be noted that this is not the most significant deterrent to participate in the screening. Looked at the imaging facilities in University Hospital of the West Indies in Kingston and also in Montgomery Radiology West. So they looked at the persons who come to their facility in town, we call it, in Kingston. Most persons who come to their facility were self-referred. So meaning, perhaps they have more knowledge than the rural counterpart in the West. They themselves presented to the facility for screening. In western part of the island, person has to be referred by their primary care physician to have screened. So we have to be put in our effort to increase the utilization and effectiveness of the screen, for especially for mammography. The program should be targeted on our healthcare professionals. I'm talking about western part of the island. So would they, as a healthcare professionals, they need to engage more, especially gynecologists, more engage and encourage the clients to have screen for their breasts. Now, we have looked at numbers, we have looked at risk factors, and I'm going to be talking about strategies to prevent cancers. We know the natural history of disease. So there are 3 stages in the disease. We all are susceptible to the disease at some point. And after that, we go to the stage where we are being exposed to the pathogenic organism. In this case, maybe any infectious agents or carcinogens or so on. So the changes are taking place inside our body, but still not showing signs and symptoms. We call it subclinical stage. And after that, after you pass that stage, you're going to have full-blown signs and symptoms of cancer or infectious diseases and so on. So each stage, understanding the process of each stage, and we can implement preventative measure or some sort of intervention. We can reduce the morbidity and mortality due to cancer. So at stage where we call it stage of susceptibility, where everybody is susceptible to and exposed to the carcinogens or any those modifiable risk factors, why don't we change? Why don't we do the primary prevention there? So persons at the second stage, where they may have a subclinical stage, even though there are some changes taking place, they may not show signs and symptoms. Why don't we detect using the screening intervention? And when we detect early, we're going to do the early intervention and we can save lives there. For those who end up with cancers, we have to improve our diagnostic intervention as well as treatment. We are talking about rehabilitative and palliative treatment for those who end up with cancers. Now, understanding and acknowledging that cancer is the second leading cause of death in the population, the government of Jamaica put a strategic and action plan that it is to reduce the burden and cost of the preventable morbidity and disability and avoidable premature mortality due to cancer by 25% by 2025. There are 6 areas that I'm going to briefly mention is in the plan. One is primary prevention and health. Second, effective screening. Third is cancer diagnostic and treatment services. Fourth is the rehabilitative, supportive, and palliative care. And fourth is the reorient healthcare sector to align with the cancer prevention and control. And finally, the area is cancer research and surveillance. In terms of reduced incidence and priority area 1, reduce incidence and preventable cancers through primary prevention and health promotion. We are looking at tobacco use, handful use of alcohol, and I said that in my presentation previously, those modifiable risk factors. Now, with the support of WHO and WHO and other external partners and even internal stakeholders, the government of Jamaica implemented the World Health Organization Framework Convention on Tobacco Control. And we are also implemented the WHO recommendations for reduction of harmful use of alcohol is part of the National Strategic Action Plan for Prevention and Control of Non-Communicable Diseases. We are less active in terms of physical activity, and Jamaica Moves is now implemented in the different sectors, both public and private sectors, and Jamaica Moves in the schools. And this is one of the success program or interventions that we have seen so far in the cancer prevention and control program. Jamaica has established a food-based dietary guidelines for Jamaica. So that's to improve the healthy eating so that to avoid being contracted the cancers. One of the beauty of the public intervention so far is Jamaica has introduced the human papillomavirus vaccine in 2017. Persons are dying from cervical cancer, which is easily be prevented due to HPV infection. And we have successfully introduced that program in 2017. Understanding and acknowledging that we have some carcinogens in our departments or facilities, and we have that the government of Jamaica has produced the guideline for management of asbestos, and also the program to remove the asbestos in our government institutions. Now, priority area 2 is screening. We have screening for cancer. There are cervical cancer, prostate cancer, breast cancer, and colorectal cancers. We have different methodologies to screen those cancer readily available in public sector and also private sector. Jamaica Cancer Societies also partner with government of Jamaica to improve the screening of those cancers. Now, I show you the structure of the Westmoreland Public Health Services, and I just want to briefly highlight how the screening, diagnosing, and treatments and rehabilitation process work in Westmoreland, or in general sense in the country. So we have primary care, where we have type 1 to type 5 health centers, where we provide different level of, many programs, preventative as well as screening, as well as curative and environmental health services, etc. So in our health facilities or health centers, we provide antenatal care, postnatal care, family health services, immunization, and part of the services, the package that we have provided in our health facility, health centers, particularly in primary health care, are screening services, screening for diabetes, screening for hypertension, screening for HIV, sickle cell disease, cancer, anemia, and so on. Or we also screen for psychiatric diseases. So if you are going to the hospitals, you may not be getting that sort of services, but I encourage the population in Westmoreland or in the country to come to our health facilities, health centers to get your disease screened. And from the point of screening, if there is a confirmation or other diagnostic procedure is needed, that person will be transferred or referred to the hospitals where you're going to be doing the diagnostic services, not the screening services. So I just want to differentiate here is in primary care, we do screening services, but in the hospitals, we do diagnostic services. From there, if there's a need for it, or if you are diagnosed with particular cancers, you're going to be given the cancer treatment, and there's need for it, we will be transfer or refer you to the rehabilitation and palliative care in the other facility, other higher facility in the country. Now, priority number 3, diagnosis and treatment cancers. So understanding, and this is one of the priority areas that we need to improve. The government of Jamaica has, I'm talking about the western part of the island, we have opened the imaging services and the Cornwall regional hospitals, and also one of the 2 National Cancer Treatment Center has recently opened in Cornwall Regional Hospital in the Western Jamaica, and provides services to the population of Jamaica, not only in the western part of the island, but also to our neighboring countries such as small islands or in the Caribbean. The persons are coming from those islands to get cancer treatment in Cornwall Regional Hospital. We have equipped that National Cancer Treatment Center with a state-of-the-art facility, and you can see from here linear accelerator such as CM, brachytherapy system, and chemotherapy suite, and so on. Now, priority area number 4, supported and rehabilitative and palliative services. So, which is something that we are working on in the western part of the island, but we have refer those individuals who need palliative care and rehabilitative care to the Sargon Golding Rehabilitation Center in Kingston to have further treatment. In terms of human resources capacity building and program management, cancer treatment is complex, and we need different aspects of the specialties and specialists are needed. Now, at this point in time, in Cornwall Regional Hospital National Cancer Treatment Center, we have radiation oncologists, we have medical physicists, we have radiotherapy technologists, we have hematologists, we also have a chemotherapy suite for a person who needs a chemotherapy, and supported by internists, internists as a medical specialist. We also have pathologists who supports the diagnostics of the cancers. And we are now producing the local specialist by implementing the training of the radiation oncologists locally. Now, everything that we do, we have to do by evidence. So medicine is evidence-based. So to have the medicine evidence-based, we also have to promote research and also need to know the trend that we just presented previously. So we have to establish the surveillance program. And in western part of the island, we have established a national cancer registry where we follow up each and every cancer patients and register them and do the our collection of the information so that can be used to implement or to draft our program in the future. And we have also partnered with national universities and international universities to have our research done locally and nationally. So far we have done research, and I have presented some of the research that we did in the past, in the West. And going back to this diagram, so knowing that natural history of cancer and different stage of the cancer, we have intervened and using those intervention, and we try to implement our prevention and control of the cancer program in Jamaica. Now, in summary, as population gets older, the chances of getting chronic non-communicable diseases, including cancer, is higher. We in Jamaican men and women have many known risk factors on both non-modifiable as well as modifiable risk factors. Evidence so far suggests that we have the population with low health-seeking behavior. There is a knowledge and practice gap, and health service providers such as doctors and nurses and others are not actively engaged in screening of the persons and not motivating the persons to have cancers, to screen their cancer status. 70% of the patients who were diagnosed by symptoms, not by screening. This is a sad reality. And those persons who we diagnose now presented with disease, which is in advanced stage, and there is not much we can do about it. We have a plan to fight against cancers, despite the challenges, both technology and human resource, and also financially. We have put in place at the local level as well as the central level how to fight cancer, and we have established a cancer program. We need to make aware of our population about where these services, such as cancer screening services, pap smear, digital examination, and so on, are delivered at the local level, and also sensitize about the referral system, how the system goes at the local level. And also, not to forget our service providers, our own people, to engage. We need to sensitize them about to engage public on the importance of screening. And we need to improve the private-public partnerships such as this, MistyBlue Cancer Care Foundation. So, you need to work or partner with the private on NGOs and to fight against cancer locally as well as at the national level. And evidence suggests that early detection can reduce morbidity and mortality. So finally, I would like to say that based on what we learned from COVID outbreak here in this country, personal responsibility is very important. We have to avoid risks. We have to do exercise. If you eat right, if you don't abuse alcohol, if you stop smoking, and you visit your nearest healthcare providers regularly, you are going to be okay. Thank you so much for listening, everybody. I know I'm go a little bit over my time. I apologize for that. Thank you so much.
Thank you very much, Dr. Ong. You have given us a wealth of information, and I know we're going to come back to it during the question and answer section, where we will be exploring some of the things that you have indicated. At this time now, I'm going to call on a cancer survivor to share her experience with us, and she is Miss Diane Corey. And Miss Diane, welcome. And could you just share with us your experience?
Thank you so much, Mr. Moderator. Good evening, everyone. Thanks for having me, Dorothy. Your experience has really encouraged me. When I think of this scripture, the Lord will turn the evil into good. You were attacked with cancer, your body, and look at what is happening now. And it also happened to me in 2014. I didn't hear Dr. Ong mention my type. Well, they did say it was a rare type. It's a sarcoma and referred to as a malignant solitary fibrous tumor. And that was found in my pelvic region in 2014. I had terrible pains, and it was resting, the mass was resting on my sciatic nerve. I'm from Westmoreland. I'm a proud Westmorlandite, but I was in St. Anne when that happened. So I got treated at the University Hospital of the West Indies. Cancer is not a death sentence. I would like everybody to know that. It's like being diagnosed with any other illness. But the important thing is to take personal responsibility, as Dr. Ong said. I was what should I say? My eating was very, it wasn't good. I had a sweet tooth. So I love a lot of cake and ice cream and all of that. And didn't exercise regularly. But now I have changed because I realized that those are important practices. And Dr. Ong did mention those. Practice healthy lifestyle. Maintain healthy relationships. First with God, with your church community, with your family members, and with your friends. Those were the persons who were right by my side, right throughout my process. And I got over in 2016. I do have a concern though for persons who are diagnosed with this type of cancer, because there has to be a process, I think it's called embolization, to shrink the tumor. And that is not offered in Jamaica. It's not done here. It was just a miracle, an angel that came and assisted. A friend of mine knew of her and invited her to come and do it for me. She's an interventional radiologist. I think that's the term. And it returned in 2018. And there is no one to perform this procedure because it's not offered in Jamaica. So it's just my personal responsibility now that is keeping me sticking to my diet, trusting in God, having faith, praying a lot, my church community praying. And that is why I'm here and I'm able to speak to you like this now. So I join with Dorothy for the private sector and whoever is listening who can assist. Don't wait until it happens to you. You know, you can do something if you can to assist in providing the resources you know, go ahead and do it. Because persons' lives can be aborted because of this illness if the right resources are not there and if they don't have the right mindset to deal with it. So I'm very happy that I could share my process and hoping that your dream, Dorothy, will be realized. And I thank the doctors who are partnering with you. And I know that although it's a few of us, as we advocate, the dream can come through. Everything is possible with God. Thank you.
Thank you so much, Dan, for sharing your experience. And as you shared, I've taken note that's something that I need to come back to you on during the question and answer section. But going through all of this, it seems so important, the whole matter of what happens, at the local level. And this is where now you need that general practitioner, the local doctor, who is going to come in and guide, because he's the very first one you actually see before you go up the other level. And this is where now we're going to hear from Dr. Lincoln Little, who is a general practitioner, hails from Westmoreland, migrated to St. Elizabeth when he went to St. Elizabeth Technical High School for his secondary education. And then he left from the States onto the UWI, but immediately got a scholarship onto India, where he went to the King George Medical College and studied medicine, and has been back now serving in Santa Cruz in a private practice as well as in the general system. And he was recognized in 1992 by the Santa Cruz Rotary Club, who bestowed on him the Man of the Year award. And his own high school, Stets, has put him in the Hall of Fame. But not so. We need to really laud him for his association with the MistyBlue Cancer Care Foundation, because he's a director of this foundation and has been given tremendous help. And so a father of 4 children, and products of his, most of them are in the medical field. So we want to salute him and want to hear from him this evening as he speaks to us about how the patient experience is linked to survival. Dr. Little. Yes, Dr. Little, you are with us now.
Hello, good evening, everybody. Let me say thank you all for inviting me to this session. You know, up to this morning, I was in a state of depression because of what happened to the West Indies team in India. But today was a great day for me because I can celebrate the birth of my first grandson, which is second. Let me say that the topic that was given to me is something I knew a little about, but I have learned a lot. So what I've learned, let me share it with you all. Firstly, let me give an overview of cancer in the Caribbean and Latin America. What is cancer? It is also known as a malignant tumor. It is a general name for a group of more than 100 diseases. Although there are many kinds of cancer, all cancers start because of abnormal cell growth and have the potential to spread to other parts of the body. And to the WHO cancer report in 2014, there were about 598 million people living in Latin America and the Caribbean, and 1.1 million was diagnosed with cancer. 600,000 people died from cancer, and by the year 2030, it is predicted that this rate will double with regard to both death and reported cases. As you can see from this graph, that prostate cancer, breast cancer, lung cancer, and colorectal cancer, cervical cancer dominate the spectrum, with prostate in male and breast in female dominating the spectrum. Common cancers are among the males are the prostate, the lung, stomach, colorectal cancer. In 2014, it was estimated that approximately 133,000 cases of cancer were reported in male, with 313,800 deaths in 2012. While in female, there were 563 new cases and mortality about 289,500 people, mainly involving the breast, the cervix, the lung, and the colorectal area. What is significant among the statistics is that more females are diagnosed with cancer, but less die. And one thing is significant is that females are more medically conscious than male. There are some points to be noted. Lung cancer is the leading cause of death for both sexes combined. Lung cancer mortality rate in female continue to increase in most countries, and all of this is brought about because of industrialization and improved standard of living, where more females are exposed to the unwelcome aspect of life, including smoking. Breast cancer rates are also rapidly increasing. Cervical cancer rates are decreasing in most countries in the Caribbean and Latin America, except in Bolivia and Chile. The risk factors, as Dr. Unger pointed out earlier, associated with cancer are many, and many of these risk factors are preventable. Cancer is most often caused by the environment rather than our innate biology. The major risk factors include smoking. Smoking causes more than 20 different types of cancer and account for 1/5 of all cancer deaths globally. Infection. Infection mainly involves the liver, in terms of the hepatitis B virus, the stomach. As much as 90% of the stomach is associated with H. pylori. The cervix, which is a sexually transmitted disease. Cervical cancer is a sexually transmitted disease. Almost all cervical cancer is associated with HPV virus, which is transmitted sexually. The vagina, the anus, and the anus is a very interesting part because, with the increase in terms of homosexuality, we're going to see a large rise in anus. The penis, the vulva. Diet, body weight, and physical activity can increase or decrease cancer. Obesity is associated with as much as 25 to 35% of cancer, especially in the female reproductive tract. Ultraviolet radiation, as we all know, association with skin cancer. Reproductive and hormonal factor. It is breast cancer on the rise of estrogen. Estrogen Environmental pollution and occupational exposure. These include substances such as asbestos, now I will enter the realms of factors associated with cancer survival. My internet is a bit on and off, so be forgiven. Cancer diagnosis can lead to emotional disturbance for both families and caregivers. It is a life-changing experience and can cause anxiety, distress, and depression. The role at home, school, and community are affected. It is important to recognize these effects and get help. Examples include cancer, relaxation, and stress management. Stress and cancer relationship. When I was going through the research, it's something which really struck me because this was contrary to what I thought all along. It is recommended that all cancer patients be screened for distress in the early stage of the diagnosis of their disease. Stress can be recognized as physical and physiological disequilibrium caused by events. There are varying views and relationship between stress and cancer. Justice, an American psychiatrist, state that stress has been shown to lead to slowing growth of cancer that are chemically induced, yet promote the growth of virally induced cancer. Really shocking. As reported by Gare and Morris, stress does not have a direct impact on cancer survival. A lot of us as private practitioners, we escape the wrath of patients because of this ill-conceived, this inconceived idea that is stress kill the patient, when basically what we have done, we have diagnosed them at a later stage to give them less chance of survival. Emotional suppression and anger. Cancer patients are nice, accommodating, and not prone to express anger nor suppress emotion. All this is basically in a society like ours, where we are Christian orientated, that people say that whenever you see somebody start attending church, start getting into spirit, they either have cancer or they are broke. Helplessness and hopelessness. Research surrounding helplessness, and hope among patients diagnosed with cancer shows that those feeling helpless and hopeless have a shorter survival time than others with better coping response. Again, Gare and Morris proved that in stage 1 and 2 breast cancer, there was longer survival in those patients who showed denial, a fighting spirit, and shorter surviving time with those hopelessness or stoic acceptance. Poor social support leads to shorter survival time. It should be noted that social support may differ or be lacking based on cancer site and stage. And of course, many doctors, they are in which even they are scared to go around these patients because of the odor associated with cancer from the cervix, those who have refused to take off that malignant breast and it become ulcerated, is almost unbearable at times. Men who were least connected to their relative survive a significant shorter period than those connected. However, here is where the female one. Women show no such relationship. Pre-treatment. Newly diagnosed cancer patients find numerous challenges. The aim of treatment is directed at long-term survival. There are many aspects of treatment to long-term survivorship. Choosing a doctor and treatment facility. Usually the doctor who makes the diagnosis will recommend appropriate specialists. The surgeon, may be the hematologist, oncologist, and radiation oncologist. Some cancers such as skin and prostate can be treated by individual specialists. for example, dermatologists and neurologists. Family member and patient are usually educated about treatment options so that they can be informed participants in treatment decisions. It is very important that treatment decisions allow preferences, needs, and desire and ensure they are all part of discussion process. May be significantly reduced because of a persistent medical condition or side effect of cancer treatment. Some of these side effects include muscular weakness, lymphoedema, paralysis, skin change, sexual dysfunction, physical deformity. It is important to identify pre-existing conditions as soon as possible after diagnosis and identify worsening or new issues during patient treatment. Rehabilitation involves a multidisciplinary approach, which includes the psychiatrist, physical therapist, and dietitian. Some patients may require prehab treatment or targeted intervention before treatment begins for improved physical and emotional recovery. Underutilization of rehabilitation is a major factor based on accessibility and additional cost to patients. It is estimated that less than 1 to 2% of survivors utilize this aspect of treatment, despite many having treatable impairment that could influence and improve their outcome. Psychosocial care. Patients with pre-existing psychosocial and psychiatric disorder may have difficulty coping, whether before or after diagnosis. 50% of cancer patients show some degree of distress. Early screening, evaluation, and timely intervention can lead to early management of their symptoms, as well as lead to adherence to treatment. Communication between patient and treating team is very imperative. Studies have shown that early psychological intervention lead to longer survival, but less than half of these patients are identified. The big problem here is non-recognition by both patient and doctor, as well as a lack of community resource and trained personnel to deal with this condition. Palliative care. This deals with treating the symptom associated with cancer and their treatment in an emotional improve their quality of pain, sexual dysfunction, not able to function at optimum, whether at work or at home, medical bills, and we all know a lot of people just seek out insurance after they are ill. It is very important for a cancer patient to get one, recurrence, lingering effect of the disease and treatment, and of course, additional cancer. Development of aftercare and survival guidelines will be beneficial in our Jamaican setting. In summary, in terms of survivalship in relationship to treatment, depend on the following variants, which include lifestyle changes such as alcohol, smoking, monitoring of patients, pharmacotherapy, including letting the patient know the side effects of their medication, education, and family support. Thank you all. And at the end of life, or towards the end, we can.
Um, I lost the last part of Dr. Little, but I think I heard when he said thank you all. Right? We want to thank him very much for his interesting presentation as he gave it. Some very interesting and I'm not sure controversial, but I want to raise a few in the discussion time, and I hope everyone that we have been taking on notes to raise some questions as we go. And now the final presentation is going to be on the attitude of patients and their families towards the disclosure of cancer diagnosis. And we're going to hear from Mr. Kyle Slush, a young man who hails from the parish of St. James, master's degree with a master's degree in clinical psychology, passionate about holistic care, not just mental care, but holistic care. And he's driven to make a significant impact on the men in the society. And so I invite now Mr. Slush to share with us on the attitude of patients and their families on the whole matter of the diagnosis.
Thank you, Dr. Young. First and foremost, I want to thank Ms. Sashwell and the MistyBlue Cancer Foundation for inviting me to speak with you guys this evening. So without further ado, I'm going to begin. All right, so we're going to be speaking about the attitudes of cancer patients and their families toward disclosure of cancer diagnosis. And there are a few points that we'll touch on. So these will be diagnosis, prognosis and perception, personality, social support, gender, and judgment, and how these points influence the attitudes of newly diagnosed cancer patients and their family as it relates to disclosing their diagnosis. So let's get right into it. So diagnosis. So a fresh diagnosis, of course, is normally surreal and a bit scary for patients with non-communicable diseases, especially cancer. So generally speaking, there are two things that are of significant importance in determining attitude toward disclosure. And the first, of course, is the type of cancer. So there are particular types of cancers that are more notorious for their mortality or their survival rates than others. And that may determine how willing a patient and their family may be to disclose their new diagnosis. So for example, cancers of the breast or prostate, if caught early, are of a greater probability of successful treatment for those. However, cancers of the brain or liver or lung or pancreas, especially dependent on the stage, may be more frightening diagnoses that might instill fear and despair within newly diagnosed patients and their family members. So that may cause some reluctance to share with others as they try to cope and come to terms with this new and daunting reality. So of course, the second is the stage of development that the cancer has reached. So if it is a cancer in situ or an early stage cancer, stage 1, then individuals might be more upbeat about their odds of beating this cancer. But if it is a later stage, depending on how they are, they might be a bit reluctant to share this diagnosis with others. Secondly, going into prognosis and perception. So the prognosis and the diagnosis is very important in determining attitudes toward disclosure for newly diagnosed cancer patients. So naturally, the average patient who receives a good prognosis may be more willing to share their diagnosis with others. So for example, cancers of the breast and prostate, according to the National Cancer Institute, have a 81 and 91% 10-year survival rate respectively. for treatment if it is caught earlier on. Therefore, patients with these diagnoses may feel more confident of beating the odds, especially if they catch the cancer in its early stages of development. So the perception might be, I can beat this thing. It's nothing to fear, because a lot of people have been treated successfully and go on to lead quite normal lives. But for other types of cancers, like the cancers of the brain and the liver, cancers of the lung, and even the pancreas, that have 12, 17, 7, and 2.2% 10-year survival rates respectively, the confidence of beating the odds for those cancers will most likely be less. And consequently, some patients may want to live out their last days, weeks, months, or years without the attention or pity from others, because the perception might be
Still there? Kyle, you still there? Go ahead.
they've relegated themselves. Are you hearing me?
Yes, go now.
Okay, what's the last thing that you heard?
The perception might be.
Okay, all right. Sorry, let me pick up from there. Right, so for individuals who are diagnosed with cancers of the breast, all right, let me pick up from there. So individuals who are diagnosed with cancers of the breast and the prostate, the 10-year survival rate, if caught early in its development, is 81 and 91% for the survival rate over a 10-year span. So these patients might feel more confident of beating the odds. So the perception might be that I can beat this thing. It's nothing to fear, because a lot of people have been treated successfully and go out to lead normal lives. However, if it is a later stage cancer, then they may be more reluctant because of the fear and concern within themselves and among the family members. And for other types of cancers, like the cancers of the brain and the liver, the lung, and the pancreas, that have 12%, 17%, 7%, and 2.2% respectively over a 10-year period for survival rates, the confidence of beating the odds of these cancers will more than likely be less. So consequently, some patients may want to live out their last days, weeks, months, or even years without the attention or pity from others, because the perception might be that they've relegated themselves to dying and there's absolutely nothing that they can do. However, as Dr. Little said before, there are some patients who have a sense of denial and they have a fighting spirit. So irrespective of the stage that the cancer has reached, they may try to fight to the end, and they may choose to disclose this to others. So the next point I want to touch on is personality. So generally, some people are more open with personal information than others. So this also comes into play when we speak about disclosure of a new diagnosis. So is this person and their family normally private and prefer to keep things in-house, or are they normally quite upfront with information of this magnitude? Pride might also come into play in terms of influencing our attitude toward disclosure. And I share a personal story. So my father was a very mysterious and private and proud man. So he and my mother separated earlier on in my life, and he migrated to the States. So I think about 7 years ago, I went to the States and I reached out to him, and at that time, he had fought off stomach cancer. So he was in remission and he was back to good health. So I wanted to go and see him. So I reached out to him and he said, you know that now is not a good time. So maybe some other time. And I said, okay, all right, cool. And about 3 or 4 months later, I got a phone call from my sister crying, and she said that her father is in the hospital and the cancer came back and it's not looking good. 3 days after that phone call, he died. He didn't tell anyone about the return of the cancer until it was too late. And I would attribute it to his pride of not wanting us to see him in that state. And at the time when I reached out to him, the cancer was back and he was in a deplorable state. So it seems as if because of the pride that he held, he did not want to disclose that information to me. So that is also a factor that influences the attitude towards disclosure for patients and their families. The next point is on social support. So as Dr. Little touched on a bit earlier, so individuals with strong social support systems may be more likely to share a new diagnosis with others than those who do not. And if patients believe that there are persons within their social support system that can probably provide some form of assistance, then they may be more likely to disseminate this information and seek assistance. But on the other hand, if a newly diagnosed cancer patient is more of a lone wolf and does not have a strong social support system, then they may be more likely to continue on that same trajectory and try to beat the odds on their own. And as Dr. Little shared with us, these individuals, the survival rate is quite low for those individuals. The other factor is gender. So generally, Caribbean women have much better help-seeking behaviors, or as Dr. Little said, they are more medically aware than men, and resultantly be more likely to disclose their new cancer diagnosis than men. So the typical Jamaican man might say, man, me not tell nobody my business because them can't help me. So this is a typical tough guy masculinity script that so many Jamaican men live by, that consequently influence their attitudes towards so many things. Another one that might influence their attitude towards disclosure is when they are the breadwinner, especially if they are the sole breadwinner of the family. So a man might be reluctant to disclose his new cancer diagnosis because if the boss find out, then he might send me home and then I'm provide for my wife and the youth then. So this is another factor that significantly impacts the attitudes toward disclosure. And the final one that I want to touch on is judgment. So individuals may be more reluctant to disclose their diagnosis in fear of being judged for lifestyle choices that may have led to the development of their cancer. So as Dr. Ang touched on earlier, improper eating practices, the lack of physical activity, the abuse of alcohol, tobacco, and other substances used for smoking, they significantly contribute to the development of cancers in the body. So these practices are unfortunately well ingrained in our society and are proudly embraced by a lot of members of our society, especially men. And while they're actively engaged in it, they are proud while they're doing it. And when these actions catch up with them later on in life, and unfortunately catch up with them in the form of cancer, they may choose to hide such a diagnosis to avoid the negative judgment and subsequent shame for their previously proud actions, such as the abuse of alcohol, eating improperly, neglecting the body by not exercising, so on and so forth. So these are some of the points that really influence patients, cancer patients, and their families' attitude in disclosing new cancer diagnoses. Thank you.
Thank you very much, Kyle. Very riveting and revealing. I want to go on, there are two questions here. The first one I'm going to ask Dr. Ong to deal with. And this one says, thanks so much for your excellent overview and data. Is it that cancer is on the rise, or is it that compared to 5 to 10 years ago, we are better diagnosing and correctly classifying the cause of death? Dr. Ong needs to be on mute.
Oh,
Go
yes,
ahead now.
all right, thank you so much. I think I saw the questions in the chat and I have replied that to the persons. Yes, so basically I was saying at my presentation is that we have improved in terms of technology. We have improved in terms of specialties and specialists who are not available, who have never been available in the past. And we have also improved in terms of private-public partnership. So some of the machines which may not be available in the past now are available. And we have improvement in terms of the health-seeking behavior, even though, the last presenter said, this is a Jamaican man, macho man mentality is still not seeking behavior. However, we are seeing men coming to our health facility. So there is a slight increase in terms of health-seeking behavior, plus technology, plus we are now establishing the surveillance system where you have a case or you have a persons who are now diagnosed with cervical cancer or any type of cancer. That person will be followed up all the way, and that trend and the behavior is going to be monitored and collect the information, and that will be used to inform the policymaker at the local level as well as national level how to deal with the cancer as the way forward. So combination of all of those things, plus we are also seeing in terms of the population structure, more persons are living longer. So if you are living longer, you're going to end up with one of those chronic non-communicable diseases. And we have high prevalence of cardiovascular diseases, high prevalence of diabetes, high prevalence of hypertension, including cancers. So when you are living longer, you are going to be exposed to some of the high risk factors. And that's how we are seeing more and more cases of cancers in the population. It may not be the true increase of the cancer incidence in the population. But
So,
historically, and knowing the high risk non-modifiable modifiable factors in the population, we know that being in a particular location, being in a particular race, is putting you as a susceptible or high risk of getting cancer.
so you're saying that Trump is not necessarily right. It's not because we tested more. Anyway, there's this there's this other question that is coming up, and I'm going to put this question to Dr. Little. The questioner says, I believe further clarification is needed on the statement of increased anal sex leading to an increase in anal cancer. Could you expound on this, Dr. Little? Could the host unmute? Yes, you are now unmuted.
Yes, anal cancer. They have found a direct relationship between HP virus and anal cancer. So with the increase, sexual activity associated with the anus, we will definitely see an increase in anal cancer.
Okay. Well, I would invite the questioner to pose some more question on that. But I would love for you to say some more on that, because it is such a cultural thing in Jamaica, but if it is related to the HPV virus, then it's the same thing as vaginal sex leading to more cancer as well. Can you pick that up?
What you must understand is that certain line, certain part which is lined by certain type of epithelium are more prone to develop cancer when they are exposed to certain type of infection or chemical. And that could be the explanation that the anal, the cervical, they are sort of aligned with that sort of squamous epithelium. And that is what is common among the cervix and the anus. So the HPV virus, that is where it like to prey on.
Okay, so
Also, you must also understand that the vulva is also an area where we see a lot of HPV infection. And that can also lead to cancer.
okay, so it's more because of the lining of
The
those
lining, the
spots.
common lining associated with these areas. It's common epithelium, and that one of the things with cancer. When it attacks this epithelium, this area lining with that type of, it is more common in those areas that have similar lining.
Got you. Another question here is marijuana smoking associated with increased cancer risk? If yes, what is the proposed mechanism?
I didn't get the latter part of it, could you say?
Is marijuana smoking associated with increased cancer risk? If yes, what is the proposed mechanism?
Okay, let me say one thing about marijuana. Personal experience. Everybody know Breeze River in St. Elizabeth. Breeze River is one of the highest producing ganja area in Jamaica. Of all my patients in St. Elizabeth, Breeze River have the highest incidence of lung cancer. And I can give you a personal experience. There were two brothers, 145 and 139. One of them called him Sensei. Let me say, within 1 month, both died of lung cancer. And they didn't smoke cigarette. All they did was smoke marijuana. What I want to say is that the mechanism of smoking, what smoking does, it cells areas that basically on rapid cell division as the oral area they are prone to develop cancer if the cells are not replicating and changing.
We're missing Dr. Little, what he's saying.
Through your mouth, the air is not filtered. So that also contributes to the development in terms of people smoking, inhaling, developing cancer. So it doesn't matter whether it's a cigarette or it's marijuana. They have the same sort of risk because of its ability to inhibit cell division. And inhibiting cell division leads to cell mutation.
Thank you very much. I want to ask Dan on something before I pick up two more questions that's coming in from the chat. Dan, you mentioned that there is a particular treatment, but that sort of treatment is not in Jamaica. Can you say some more? Remind us of what treatment you have mentioned, and you know, probably what you think we can do to get that sort of treatment in Jamaica.
Okay, the procedure is called embolization, which is the shrinking of the mass. Most times the tumors are too large for the debulking process to be done, which is the removal of the mass. So what the doctors usually recommend is chemo. But I did the chemo for 3 months and it didn't shrink the mass. In fact, it got bigger. So the first procedure that interventional radiologist recommended was the embolization, and she came and did it pretty well, but it's not offered here.
And
You have to.
is that treatment related to only your form of cancer, or is it
Tumors, I think tumors.
tumors in
Just tumors,
general?
yeah.
Uh-huh.
Because they have to shrink it once it's of a certain size.
Uh-huh.
Because they tried, just to tell you my first experience, they tried to remove it without doing the embolization, and I almost died. I bled a lot. They had to do blood transfusion and all of that.
Thanks so much. Could Dr. Ong, you want to comment on that? Dr. Ong needs to be unmuted.
Yes, Mr. Chairman, my short answer is no. It's not my field, so I don't want to comment on it.
But you don't know anything you can share in terms of are we on track somehow that it's something that needs to be explored?
Okay. Yes, of course. We constantly looking at the common, like I demonstrated in my presentation, what are the commonest trends or commonest cancers that we are seeing. We are focusing on at this point in time. One at a time, we're going to focus in on how can we control and prevent these commonest cancers which is happening in the country, and associate that with some of the technologies or some of the methodology or modalities that we are going to provide to treat cancers. We are coming from the long way, Mr. Chair, I have to say it, because in the past, we did not have a linear accelerator in Cornwall Regional Hospitals. Since the establishment of the National Cancer Treatment Center, we have established that type of modality in 2017. Previously, we are asking those individuals to go to KBH or Kingston to get that sort of treatment. So we are improving in little step at the time, based on the challenges that we are seeing. But so far, breast cancer, prostate cancer, colorectal cancer, and those commonest cancers are being effectively treated in the Cornwall Regional Hospitals, which I can comment on.
Okay. Here's another question. Persons are skeptical about the HPV vaccine. What are your thoughts? And I will throw this to Dr. Little. Could we let out Dr. Little? Yes, you lock him up back again. Let him out now. Yes. You keep on letting him out and going back. Dr. Little, go ahead.
What I'm going to say is that it's the benefit which outweigh the risk. And since we have seen that many people are benefited from taking the HPV vaccine, I would say it's safe and people should go ahead and take the vaccine. Every medication has its effect. I have seen what we must all realize: aspirin have killed more patients than any other medication. But on the other side, aspirin have saved more patients than any other medication in this world. So what do? Go ahead. The benefit of using aspirin is more. It's the same way I would say with HPV vaccine. It is more beneficial to people than the side effect that is created by giving it.
All right. So you're saying yes, there are side effects and side effects for other things as well.
Well,
right? So we need to do a cost-benefit analysis.
As I say to people, and one of the big problems I have is when you're giving patient anti-cholesterol treatment. And I tell patient clearly, I have not seen one patient dying from using the anti-cholesterol drug. But I have seen a lot of people dying from Santa Cruz to say Mandeville in a motor vehicle accident. Do you stop traveling in that motor vehicle? They don't. But still there's higher risk than using this medication. So it has to be weighed. It has to be weighed. And the benefit far out the risk.
Thank you very much. I want to pose this other question both to Dorothy and to Kyle. It says, how can we deal with the inflated cost associated with cancer screening tests, especially for advised MRI tests? Let's try Dorothy on that one. Let her out. Yes, you're let out now, Dorothy.
Okay. Thank you for that one, Mr. Moderator. What I have found from the perspective of being the chairperson for the foundation, where we have had persons coming through our healthcare system, or even persons in the community coming to us because of the position that we have with the foundation, and the cost factor is a huge hindrance. It's only last week I had about 3 persons. One lady in particular, she sells callaloo in the market, and she was asked to do an MRI. She said, "Miss, how much callaloo will I have to sell to be able to afford to do an MRI?" And that is one of the challenges that we are having in Westmoreland. Because if I may expound a bit, one of the things that Dr. Ong spoke about was the makeup of the Westmoreland population, where you find, especially in the eastern part of the parish, where they do mostly farming, and more often than not is subsistence farming. And therefore you find that more persons may fall below the poverty line. And the services that are offered in terms of MRI, it's in Montego Bay. And even the very factor of them affording transportation from Westmoreland to St. James to have the test done is a challenge, not to mention the challenge of being able to afford to do the screening itself. And the high mortality rate that we have speaks for itself in terms of the huge challenge that persons are having accessing these treatment. Because with cancer, one of the things that you have to look at is the immediacy of treatment. And you find that persons are having to wait sometimes up to a year before they can access the appropriate treatment, because they're not able to afford to have these services done. Indeed, you have the government has now partnered with some private sector organizations where they can go into private entities and have some MRI done. But then again, you have some of the biopsies that have to be guided, for example, by other electronic medium, and the financial backing is just not there. And therefore you find that persons are not able to access what resources are there in terms of machinery, because they can't even afford the transportation costs from Westmoreland to St. James to have it done. And then you ask yourself, how do we move forward? Indeed, we have to commend the government in terms of what we now have in St. James, because we never had that a few years ago. We had to travel to Kingston. Yes, we have it here now. But for persons outside of St. James, and I'm going to go back to Westmoreland, of how much benefit is that to us? And it's not because we are being ungrateful, but it's in terms of accessibility and how that is addressing our needs in terms of giving a solution for treatment in the parish of Westmoreland.
Thank you. Kylie, Mrs. Slosh, you want to add to that?
I think she did a very good job in summing it up. I don't think there's much I could add to it. It really is what it is.
You're not doing a Dr. Hong to say that it's not your field.
It really is what she's saying it is. There's not much more that we can do about it where that is concerned. It's not like there are medication where you have generic types that are probably a bit cheaper. It really is what it is, and the socioeconomic background of most of the individuals that need these services, as Ms. Dorothy said, they really can't afford it. And it's just unfortunate, actually. There's not much that can be done until we have made more strides in terms of providing these types of screening tests and MRI tests within our local hospitals as opposed to just at the Cornwall Regional Hospital or in Kingston. So until we're at that stage, there's not much more that we can do right now.
Thank you so much.
You're welcome.
There's the other question here. It seems that doctors are reluctant to explore alternative medicine in the treatment of cancer. Chemo hardly seems to work. Isn't there value in exploring this area? I guess it's alternative medicine. Who want to take that out? Dr. Hung, don't tell me it's not your field. You need to let him out.
Yes, yes, sir. Thank you so much. Of course, I think alternative medicine, it has been with us from the beginning. So we cannot disregard every approach that we make to the patient. We also have to work with the alternate medicine. But there are some science and science things that work together. However, being a doctor, based on the evidence, if I may, I could go back to HPV vaccine that Dr. Little answered the question clearly, but I would like to support his answer by way of saying we have introduced HPV vaccine using the 50 or 60 years evidence around the world. We are introducing at a very late stage, and we have not financial status at that point in time to introduce it. But based on the evidence that we are seeing now, is the cervical cancer is the second leading cause of death among women population. So we have to introduce this for the benefit of the population, and all over the world, all over the scientific community, the benefits have been unquestioned. Even though Dr. Little mentioned about some side effects, yeah, everything has side effects, but the benefits outweigh the side effects. And in this HPV vaccine, its own benefits has huge than we're looking at small amount of side effects. Just going back to your question about the alternative medicine. This is one of the interesting things that I found. That I've been living in Jamaica for almost 35 years. And in this country, the hypertension and diabetes are most prevalent diseases in this country. So when you ask someone with hypertension and diabetes, almost 75% of the population with those chronic non-communicable diseases are using some form of alternative medicine. And they may not necessarily tell you they are using it. They have different kinds of alternative medicine. Actually, we have done a study on it, and we are now analyzing to publish it. So alternative medicine, as long as it is not going to harm the management of a cancer patient, we support it. Doctors are not hiding it. Doctors themselves, some of us are using the alternative medicine. So, like I said, this is a part of the treatment.
Yeah, but if a patient says to a doctor, I'm using this, the doctor may tend to just ignore the law, to pass on. So the patient may not be encouraged to explore that anymore. Dr. Ong is muted.
All right, it depends. It depends on what type of alternative medicine that you are using. Some of the things are obviously harmful to you, because I have seen persons with cancer, with breast cancer, and for whatever influence the person has, the person come for the diagnosis was established, and when we have decided to do the mastectomy, the person just run away or disappear from the system, and we found her like 1 year later, and both of her chest are being eroded by both breast cancer. And that's what we found out. She was using the medicine woman in the community, and that's where she was getting some sort of ointment and being influenced by the community members, and she was using it, and we have lost her. So if I know that type of, disclosure is also very important, Kyle said about it. If you have not established the proper communication channel or trust between clients, or in this case, doctors and patient relationship. You have to establish that first. So the clients or patients will disclose all the information, all the medication, or all the technique, or everything that she has been using and disclose to you. So depending on what type of alternative medicine that he or she is using, I would look at it as a doctor. I would research it, and if it's nothing harmful to the persons, even though I may not necessarily say that I support it, but I'm not going to be saying don't do it. But if there is an obvious harmful to the patients, I'm going to say no, don't do it. So we have to engage in all aspects of the management of the cancer patients, not only with the chemotherapy, not only with the radiation therapy. You have to establish the patient trust, patient-doctor relationship.
Okay. Well, I think we have done quite a bit during the session. And as we wrap up, I'm going to invite our patron, Honorable Makala, to give a closing word.
Well, I have to be unmuted.
Yes, you are now.
Yes. Well, as I sat and listened to this afternoon's to the various presentations, I found them extremely enlightening. And I hope that our viewers, all those listening, found it as interesting and educational as I did. From all the presentations, we now have a greater understanding of what is involved in this disease of cancer. And the session also highlighted the fact that there's a lot of work to be done. And when we heard from Chairman Satchwell about the need for persons to be assisted and the challenges that they are facing, it is clear that this is something that all of us have to come together to consider the way forward. And we have heard many recommendations. We have been enlightened. It has been a rich learning experience. And I hope that going forward, we'll be able to have more assistance from various entities so that the work, especially being done by the foundation, can achieve greater success. But this is a wonderful beginning, and I certainly look forward to the other presentations.
Thank you
And
very
just to thank wholeheartedly all those who shared with us this afternoon.
Thank you very much, Justice Makala. It has been really a very educational experience as we went through. I asked certain questions as we started. What is cancer? I know that I am more enlightened now of what is really a cancer and why do we have cancer of this, cancer of that, knowing that it is a malignant tumor, and malignant tumor can spring up in any part of the body. I'm not sure if I got the answer, can it be prevented? Because the science is still out on really what is the cause of the various ones. So there are further studies to be done there. But how can we take care of ourselves when inflicted with this disease? I think we have gotten quite a lot of lessons on that. And we have seen through the discussion here this evening, the importance of a foundation like the MistyBlue Cancer Care Society, giving help, providing education to persons how we can treat with it, and getting some information on not just treatment, but how do we care for ourselves mentally and physically during the period. So I'd like to wish the foundation all the best as we continue the education. I think the next emphasis will be delving into prostate cancer, Dorothy, for in September, as that is the emphasis there, and there are several taking us right to November. Probably you could just highlight, give us some advanced preview of those other sessions that we will be dealing with going onwards.
Okay, thank you, Mr. Moderator. For the month of September, we know September is prostate cancer month. So the second Wednesday again, same 6 to 8 p.m., we'll be looking at prostate cancer. And again, we have a number of specialist persons who will be coming on board to have the discussion. So we are inviting persons to come back for that time. And I can tell you that there are interesting days ahead, especially where prostate cancer is concerned, because we have a lot of generalizations that we have in terms of the responses that men have towards the treatments that we have for prostate cancer. And therefore, I believe that we'll have some surprises coming out there. For the month of October, we'll be looking at breast cancer. And breast cancer is one of those one that is very delicate, and we tend to look at it as a cancer that affects women, but men too have breast cancer. And hopefully we'll be able to have one of our males who have had breast cancer who will be coming on also to have discussions with us about his experience. For the month of November, we'll be looking at stomach and lung cancer. And for December, we'll be doing cervical and ovarian cancer. So those are the ones that we have lined up for the rest of the year. And as usual, it's the second Wednesday of each month, and it is from 6 to 8 p.m. And we look forward to more persons coming on board. And to remind persons also that we're also accrediting 2 CME credits for persons who have come on and participated. They just need to get back to us, and we can make arrangement for those certifications to be ready for them. Okay. And thank you ever so much, Mr. Moderator. You did a fantastic job, and also to all our presenters.
Thank you all, and all the best.
Okay, thank you.
Yes, ma'am. Have a good night and keep safe, everyone.
Okay, thank you, madam. What's your thought, Ms. Dr. Ong? How was it?